presentation is going to be on spinal protection, and we're going to review the 2020 protocols in reference to spinal protection. We're going to cover vehicle extraction. We're not going to talk about the KED tonight. That's going to be in the following class because that takes up almost a whole class. And then we're into cervical collars and backboarding. So my first question
Hey,
is,
Barry,
does any...
real quick, do you want to put that into view mode so that you can see the
Yeah,
slide?
I'll do that.
Yeah, okay, there you go. I'll shut up now.
Is that better? Okay. Yeah, because it does goofy things. Okay, so before we get this started, I want to ask everybody, does anybody know what the protocols are for backboarding and collaring? No dumb answers. Speak. Nobody's gonna take it. How many people remember that we did not backboard if the patient was ambulatory? Remember that? And we only put collars on when they're complaining of neck pain. Remember that? I see not. Well, it's a little different. So we're going to talk about, I'm going to show you the actual breakdown. So as you can see, I'm hoping everybody can see the screen there. But for a high-risk mechanism of blunt trauma and one of more than the following will receive a minimum of a cervical collar, all patients. So you have a midline cervical, thoracic, lumbar spine pain, tenderness of deformity, new paraplegia, quadriplegia, focal neurological deficit, altered mental status, or distraction injury, any injury, fracture, chest, abdominal trauma. If no to all these, spinal protection is not indicated. Additionally, for patients who have not yet reached their 15th birthday, neck pain, high impact driving incident, or high risk MVC, substantial torso injury, conditions of spinal injury, inability to assess or any of the above. If yes, any of the above, minimum of a cervical collar. Does the patient have one of the more of the following: neurological deficit, sensory, GCS less than 15, inability to ambulate, unable to respond during assessment? If yes, we do spinal immobilization. No, spinal precautions apply, cervical collar. Does everybody understand that, what that means?
And so I think it's important to note that there's a difference between spinal precautions and spinal immobilization.
Right.
It's changed. It's flip-flopped back and forth for the past, 3 or 4 years now on how they want us to do it, when they want us to do it. So I think reviewing that protocol like that is very good.
Right, so we're gonna actually go down through the difference, just kind of grab the highlights of it, because when I first started, we backboarded everybody who was in a car accident. And then, of course, things changed. So there's a lot of new stuff in here that's really information. So like Jamie is saying, we have spinal motion restriction refers to the act of protecting the spinal cord from further injury. And spinal immobilization is the act of placing a patient on the backboard with a cervical collar for the purpose of trying to prevent excessive movement of the spinal column. At one point, there was a lot of talk about that we're doing more harm by putting a patient on the backboard than good, but now they've kind of revised it again. So we're going to keep going through this. Spinal motion restriction is a patient who has a blunt trauma with a high energy mechanism of injury that has the potential to cause spinal cord injury, or vertebral instability, or in one or more of the following should receive spinal motion restriction: a midline cervical, thoracic, lumbar, spine pain, tenderness and deformity, signs and symptoms of paraplegia, quadriplegia, focal neurological deficit, altered mental status and distracting injury, an injury, fracture, chest, or abdominal trauma associated with significant discomfort that could potentially distract from a patient's ability to accurately discern of spinal column pain or tenderness. So any questions there? I know I've kind of stuttered through it.
To add into that, it should be noted, it's not in the protocol, but from a child safety seat perspective, Any child that is forward facing in their seat under the age of 4, any car accident is going to be high mechanism for them because their vertebrae have not fully formed, which is
Right.
why the recommendation is to leave children rear facing until they max out, which is usually around 50 pounds and at 3.5 to 4 feet tall.
So as you looked at the original chart, this is where we talk about children 15 years of age or older. This is, I'm sorry, let me back up. Indication referral to adult specialty spinal center. So where do we take our trauma patients to? Question? Come on, Andrew, I know you're going to answer it.
The trauma center?
Yeah, where's our trauma center?
Oh, PG or Washington Hospital Center.
Right. Signs, symptoms of new paralegical process. Patent airway, excuse me. Moving on down. Treatment. This is straight out of your protocols. All patients meeting the spinal motion restriction protocol shall have a manual inline cervical spine stabilization and application of correctly sized cervical collar. Minimize the fluxation, extension, and rotation of the spinal column. Patients meeting the spinal motion restriction protocol who are neurologically deficit and not able to amputate on their own accord shall be immobilized with a cervical collar and a backboard. Later in this presentation, we have some pictures and slides of the proper way to extract a patient out of a vehicle and put them on a backboard. We are not going to cover the CAD tonight, which is actually, we will go into more detail on that as we go further along. See, patients who are found by EMS clinicians to be standing or ambulatory, the following patients only need application of cervical collar, do not need to be placed in a full mobilization with a backboard. Patients who are found by EMS clinicians to be standing or ambulatory, that's what we had last year. Patients who have a GCS of 15 and are able to safely extract themselves from the environment, vehicle seat without gross movement, fluxation, extension, rotation of the spinal column, and patients who do not have evidence of neurological deficit. So they have put in here, if they are ambulatory, they do not have to be backboarded. Does everybody know what I mean by ambulatory for our new people? Yeah, basic up walking around. Patients who are placed in a cervical collar without the need for mobilization on a backboard should be assessed in a minimal movement to assist in minimal movement to the EMS stretcher and allowed to lie down in a supine on their own accord. Patients meeting the spinal mobile restriction protocol are not requiring mobilization with a backboard should be secured to the EMS stretcher in a supine position with the head elevated at a 30-degree angle. Backboards may be used to extract the patient and patients transferred to, and back up, let's try again. Backboards may be used for the patient extraction and patient transfer for patients not meeting the spinal mobilization restriction protocol. However, other devices are preferred: sheet, Reeves, scoop. If the backboard is used for extraction from the scene to an ambulance, the patient should be removed from the backboard as soon as possible. The stretcher mattress will provide support in place of the backboard. Transport patients who have already been removed from the backboard should not be placed back on the backboard prior to transport. Does that make sense? Anybody want to talk about that at all?
We don't do a lot of interfacility transports, but in the
No.
rare occasion that we do, if the doctor has taken them off a backboard, we should not be putting them back on one.
Patients are backboarded prior to EMS arrival. If the EMS clinician finds the patient mobilization on the backboard applied prior to arrival, the principal spinal mobilization restriction protocol still apply. How many times have you guys seen where somebody will put a patient on the backboard, and as we're moving that backboard out, a provider will come up and say, take that person off a backboard. I can tell that's happened to me a few times in the past years when a medical come on scene and say, take them off the backboard. But as you see here, no, we do not. Helmet removal. Anybody been involved in helmet removals at all? No? Okay, Jamie, why don't you tell us a little bit about it?
Well, you're only supposed to remove it if it's going to interfere with the airway. At least that's how it used to be. But when you do remove it, you need at least a minimum of 2 people. And it's you got to kind of put your hands up and you kind of like thread your hands under the outside and move them up and pull it up while maintaining somebody else is maintaining C-spine. It's actually pretty difficult to do.
Right.
So if it is like a motorcycle, like they wouldn't have obviously shoulder pads.
Shoulder pads, right.
Football players, you're going to leave the helmet in place, but like somebody on a motorcycle, if you have to take the helmet off, like I said, minimum of 2 people, 1 to hold C-spine and 1 to actually remove the helmet. And if it's not, affecting their airway, you can leave it in place. So
Right. So it says here, if a patient is wearing a helmet and no shoulder pads, removal of the helmet is indicated. If the patient is wearing a helmet with shoulder pads, removal of the helmet is acceptable only when concurrent with removal of the shoulder pads. Under these conditions, removal of the helmet is indicated for management of the airway or other facial trauma. Children less than 15 years of age for spinal mobile restriction. Sorry about this, guys. We only have a couple more of these slides and we'll get away from this. Patients who have blunt trauma with a high energy mechanism of injury that has a potential to cause spinal cord injury or vertebrae instability in the presence of the inability to assess 1 or more of the following should receive spinal mobilization restriction. Midline spiral pain, tenderness, deformity, signs and symptoms of paraplegia, focal neurological deficit, altered mental status or disorientated, distraction, injury, or neck pain and I can't even pronounce that word, sorry. So where would we find mostly young people? What is the big one for spinal injury besides automobiles?
sports.
Sports is a big one. Dirt bikes, football. Okay, indications for referral to a pediatric trauma center. Patients less than 15 years of age and signs symptoms of near paraplegia, quadriplegia is present, patent airway, and I can't even pronounce that word.
Hemodynamically stable.
Thank you. Sorry.
It's okay.
All patients meeting spinal mobile restriction protocol shall have a manual inline cervical collar stabilization and application of correctly sized cervical collar, minimum flexation, extension, and rotation of the spinal column. Patients meeting the spinal mobile restriction protocol who are neurologically deficit, not able to ambulate on their own, or who will be unable to respond during assessment shall be immobilized with cervical collar and a backboard, just like the adults. Okay, we covered all that. Patients are placed in a cervical collar without the need of immobilization on a backboard should be assessed in middle movement on the EMS stretcher and allowed to lie down supine on their own accord. Cover that. We covered that one. Okay, we covered that. Patients found with a backboard applied before EMS arrival. If EMS clinicians find a patient immobilization on the backboard applied prior to arrival, the principal spinal mobile restriction protocols still apply. Okay, protocols are done. Any questions before we go into the fun stuff? Nope. Okay, cervical collars. Cervical collars come in a variety of shapes and sizes and construction. Nevertheless, their design is relatively uniform. The collar is designed to prevent the patient's chin from dipping down towards the chest by placing stiff foam or plastic between the shoulders and clavicles and the chin. The section of the collar is held in place by a posterior section, which wraps around the posterior neck and is anchored in place with a loop or hook fasteners. Sizing of cervical collar. The length and width of the neck, the The length and width of the neck varies from one person to the next. So we know we can't say one size fits all. It's crucial to note that the height of an individual has no relation to the length of his or her neck. In other words, a very tall male may have a very short, squatty neck, while a petite female may have a very slender, long neck. In order to pick the correct cervical collar, you must measure the neck. As you can see here, you can use the hand, so you support the patient's head. Remember, whenever we're going through and putting a collar on, your one provider must support the head. Achieve a lateral view of the patient's neck by looking from the side of the body. Bring your fingers and thumbs together as if you're going to salute. Rest the outstretch of your hand on the base of the patient's shoulder, pinky finger side down, just like the pictures there. With your eyes drawn on imaginary lines sticking straight forward from the bottom of the patient's chin, note which fingers match the level of the imaginary line. Counting the number of fingers from the pinky to the imaginary line. For example, if your index finger matches the line, you'll have 4 fingers worth of space to fill in the collar. Adjust the cervical collar by measuring, let's see below. Make sense so far? Am I bored, everybody? Yep. Place the spherical collar on the patient. Do not remove stabilization when applying the spherical collar, as they've done here in the picture. You can see in the upper picture they're holding stabilization. As he's putting the collar on the 4 slides below it, you notice that nobody's holding the head. So you bring the collar from the front end, wrap the collar around, wrap the strap around the back, and look at the face to make sure you're properly supported and you're not choking the patient. Once secure, the collar should be snug enough to keep your patient from nodding his head downward, but not so tight to keep him from opening his mouth. Adjust the collar as necessary until it fits correctly. If the wrong size collar, replace it immediately. So how many size collars do we carry in the unit? Nobody can answer me? We carry adult and pediatric. Size of cervical collar, cervical spine backboard. The collar only really controls the flexation movement of the cervical spine. The rotation movement, if indicated, is restricted when the head is mobilized, and extension movements are restricted with the backboard. To prevent hyperextension of the head and neck, padding between the occupant and the board must be used. The vast majority of the patients are mobilized. Does everybody understand what you mean by padding the patient? No? Yes?
Where we fill in the voids so that there's nothing hard pushing into the patient to cause possible discomfort or injury.
Right, especially in older people because their spines aren't exactly straight.
Hey, Chief, are we going to use just rolled gauze for that? Like, I've never had to pad a neck because I was always worried about cutting off blood flow or oxygen. So that one's kind of new to me.
You can use rolled gauze. You can use a pillowcase, anything that is soft and squishy, just to fill the voids. It doesn't have to be packed in like you're packing a suitcase, but to try and make sure that nothing's going to poke them or prod them or anything like that.
That's also why we carry towels on board, especially down in the lower spine. With our protocols, when we do our ambulance inspection bag, we're required to carry so many towels. Like Jamie said, pillowcases work very good too. So this is going really back to basics. So we have a patient on the ground. Now we need to put them on the backboard. So as you remember in EMT class, the person at the head holds stabilization, and that's the person who calls the roll. You roll the patient. The person at the head is lead. You examine the back of the patient. Once you've examined the back of the patient, you roll it additionally approximately 10 degrees further towards you to slide the backboard underneath. Then you roll the patient back on the backboard. And who can describe if the patient isn't exactly on the backboard, how would you move the patient? How about a new EMT? Come on, somebody.
All right, so you're going to maintain control of the head at the same time. You're going to slide them down and back up again, repositioning in the direction of the spine.
Right. And you notice how the person in the middle slide is right around his hips? He's the one really creating the support. So like you said, you always make person who's holding the head never lets go.
And they're the ones who are in charge.
Right. Okay, now we go into vehicle extraction. How many people have actually had to extract a patient from a vehicle?
Me?
Me? All right. So when do we enter the vehicle on MVC?
When
Once the fire department says it's safe.
After
Yes.
it's stabilized.
And not before. Not like the cluster we had out in front of the building when the truck rolled over and everybody started running in. You
That-
did not,
Just
Unless
so you know,
the fire department has said you need to get in there to help the patient and they will stabilize it for you.
right.
it's also put out at the EMT school. I don't know what they teach in paramedics, but EMT school, they tell you that if it is imminent danger to the casualty, then remove them. You don't wait for stabilization if you don't have to, if you're able to maintain your safety. But like the vehicle's on fire or something, you can pull them from it.
Right.
The life over limb rule. So
Right.
yeah, if the car's on fire, getting ready to blow up, grab a leg, grab a foot, grab an arm, yank and pull.
Okay, so here's our example. Okay, here's our example. We're going to go through vehicle extraction, and it's not the easiest thing in the world. Sometimes it's very difficult. But you notice our first provider is in the back seat holding stabilization. That person will not let go until they turn over that stabilization to the next person during the extraction. Notice how she's reaching around and supporting the head, the neck. Okay, here's Victoria. She's measuring for the collar. The person in the back is still holding stabilization. She brings the collar on. Once again, do not release stabilization. That means the person you have to work around them. Bring the collar up nice and tight. Okay, so now we have to get the patient out. The easiest way to do this is to put the backboard on the stretcher and raise the stretcher up to about sea level. And you want to slide the taper into the backboard underneath the patient's butt as best you can. This is not the most graceful thing, but you have to do it. Any questions so far? So once we have the backboard underneath the patient's butt.
I will, just a hint here for people, when you're trying to get that underneath their butt, most seats you can push down on without moving your patient. So it may help to put a little pressure on the seat as you're trying to slide it under.
So you carefully roll the patient onto the backboard. And this is the hard part, and this is where the kids actually helps you out a lot, and we'll go into next time. Notice we still have stabilization. We lay the patient on the backboard, once again, holding manual stabilization, and we keep providers on both sides of the backboard, so we slide the backboard onto the rest of the stretcher. Now the strapping. When you're applying the spider straps, now of course we use disposable straps. So do we start at the shoulders first or the feet first? Questions? No comments?
Shoulder.
Victoria, I can hear you chomping. You want to tell us? Victoria? No? Okay, so you start at the shoulders. The next diagram will go into exactly the placement. Why would we start the shoulders? If you're backboarding a person like myself, if you start the feet, you may get up to the shoulders and you don't have enough strap left with spider straps. Consequently, in this case, this patient is very short. If we started at the feet, we'd have too much spider strap at the top. Okay, here's a diagram. So once the patient is in position, apply the padding to the voids between torso and the backboard. Check for PMS before applying the straps and after applying the straps. So we secure the shoulder straps first, then the midline torso second, and the legs and knees last.
Barry, do we still have 9-foots on the ambulance?
No, and thank you. So I'm a 9-foot person. I really like 9-foot straps. I would love to do a class of 9-foot straps. Once you learn 9-foot straps, you'll never go back to them. We used to use, when I first started, we used to use quick
disposable
straps.
ones that tape on themselves.
We mainly use disposable straps. The downside, the disposable straps, the yellow ones, everybody can tell you you're on the scene, it's chaos, and you pull the tape off and the stickiness sticks to your gloves. Total pain.
It is a pain, but the clip-in ones are a lot nicer, but then you have to have the clips already put on your backboard. I prefer the 9-foot. I can use the 9-foot disposables, no worries. But anybody using a spider strap, if you pick spider straps up, please, for the love of everything holy in this universe, roll it up the way it's supposed to. Make sure they're velcro to each other, not in a giant ball, because I sometimes want to hurt people when I take it out and it's all velcroed in a giant ball. Just
In
like
fact, Victoria, tomorrow night we'll take pictures of the proper way to roll up a spider strap. You're absolutely right. Okay. Jamie, wasn't it true several years ago we were not allowed to use disposables we were flying a patient, or is that a misnomer?
it was a misnomer. I've never heard of anybody not being able to.
I thought that was a while back that they said, okay. So here's a hint for you guys. When you're putting the straps on, you're trying to get the straps through the loops of the stretch, through the backboard. If the person doing stabilization puts their knee under the backboard right underneath the head and elevates it just slightly, it makes putting the straps on or your disposable straps so much easier. It takes a little bit practice, but once you learn how to do it, and it also helps when you're putting the head blocks on. And you do have knees that can support. Okay, now we go to blocking the head. So once again, you still keep manual stabilization until the soft blocks are applied. You put one on each side. Once you have them on each side, you can release. Then you put the bottom strap on around the lower chin. Tape is not allowed anymore. All those old school people like doing the tape and folding tape. We're not supposed to use it, even though I see it all the time. Right, Jamie? Come on, you're muted.
I wasn't saying, I was making my surprise face. Like, seriously, where does it say that?
That was quite a while. That was about 2 years ago. We were told no more tape allowed.
Yeah, that was put out in EMT school too. They busted
Yeah.
some paramedic that was teaching us tape, and then Chief tore into his ass too.
Yep, we're not allowed to use tape.
My accident, they taped me up. I actually had to have part of my hair cut because they taped the hair to the board.
I mean,
That's a good reason. But
does
yeah,
it say it in the protocols? I mean, does it literally say do not use tape in the protocols? Because unless it doesn't say do not use tape in the protocols, you can use tape. Like,
I'll have to find out where. But yeah, we were chastised for using
You're a renegade.
I am.
Better talk
Yeah,
to
we'll-
Oakville too, because they still use tape.
We'll take a look for that.
If you check
Also,
my-
you'll notice in your collar bag, you'll have straps for strapping the head. They're kind of they're a foam strap. Okay, so you start with the bottom, then do the top. Once again, having that knee under the backboard makes it so much easier to connect. So remember, to immobilize the torso first, follow, oh man, get that out of there. Okay, the key areas to apply the appropriate straps are primary points of contact between the body and the board, which are the shoulders, the pelvis, and the occiput region of the head. Any questions on strapping? No?
Do you know how many sets of head blocks we have on the unit?
There's a minimum of 2 pairs. We carry more, but there's a minimum. There's always 2 pair in the bag, and you always find an additional 1 or 2 pair up on the shelf in the backboard cabinet.
So for our newbies, instead of us old farts, if you don't have head blocks, how do you secure the head?
Rolled up sheets or towels.
There you go.
Yep.
That's right. That's why we also have those towels. You can roll them up and secure them with the devilish tape.
Blanket roll.
If they're wearing shoes, you could take their shoes off, place them on the sides of their head, fill them, and tape it to the sides too. Why are you laughing? We do it in the Army all the time. We take boots off them. That's how we stabilize neck and head.
That's amazing.
Please don't do that.
I
Oh,
love.
genius. Please don't do it. Use a roll up
Also,
blanket and tape.
you will see there's some foam rolled head blocks. You'll see those popping up more and more. And a lot of times they're actually connected together that go underneath the head. Important, this is really important to remember, pad all voids between the body and the board. We repeat this numerous times. It improves the patient's comfort and may help to prevent further injury from the immobilization itself. Finally, just like the cerebral collar, one size does not fit all in terms of immobilization techniques. Some patients with excessive curvature of the back and neck or with lower back disorders may need significant padding or flexation of the knees in order to achieve a neutral pain position of the spine. It's not necessarily, you may actually have to really support one knee depending on the injury. Right way and many wrong ways. The equipment we use is only as good as our technique. It's important to remember that there is a right way and a wrong way to use a device. We do not want to cause further harm to our patients, which can avoid by making sure we use cerebral collars appropriate and correctly. Wow. Okay, I went through this a little quicker than I expected. Sometimes, wow, it's only 35 after. So any questions about backboarding and collaring? No? So what else besides we talked about splints the other night. Can you use a backboard as a splint?
Yes.
Definitely.
Yes.
Yeah, when you have more than multiple injuries, a backboard works perfect.
Hey, I got a question on scene. When you're extricating a patient, are firefighters taught non-EMT or non-medical providing firefighters? Are they taught the exact same stuff like this? So
my eyes are rolling into the back of my head right now because no, they are not.
that was yeah. So they're the ones that give me right to get in the vehicle, but they have no idea how to.
Correct. The
Yeah,
patient is yours.
okay.
The scene is theirs. So they should be referring to their officer who is supposed to have at a minimum EMT to allow them to be able to tell you if the patient looks like they're in serious critical condition. A lot of times I will ask them if I can walk over to the window and do an assessment without climbing in the car to determine if we need to do this rapidly or not. Yeah.
All right, so then that opens up a whole nother door. And I'm sorry to jump in your class.
No,
here,
it's good because
like Andrew had an issue. One of the first times Andrew and I got to talking about it, I was teaching a class, and at the end of it, he came in and he had mentioned about having an issue at at a scene where there were two patients. The asshole in charge of the scene told him to go to the lesser important patient, and he, being the paramedic on the scene and the only paramedic on the scene, said, "Hey, this other person is a higher priority, and I think I can do something for him. Let me get into it." And there was a pissing contest. So I got it. He wasn't the officer on scene. Fast forward this story to wagon burners on the scene, and I'm willing to stake a fight with an asshole firefighter. How is that supposed to be handled chief-wise? Like, what are you expecting?
So Andrew and I had a very long conversation about this call. I remember it vividly in my memories. And basically, you have to do what's best for the patient. So Andrew, as a new provider, brand new, I mean, I think this was like less than a month after we cut him loose, doesn't have the street cred that I do to go tell somebody to go pound sand. So in the reality of things, for a newer provider, if you're in that situation, my advice to you would be to tell the firefighter, hey, I'm going to rapidly evaluate both patients. And then once you have done a rapid evaluation of both, you determine which one requires the most assistance, kind of like triaging in a mass casualty, and just inform the firefighter that, this is how it's going to work, because the patient is your responsibility. Whereas you have, firefighter Joe Schmo, who may or may not be an EMT, because we don't really know all the time if they are. So that's the most diplomatic way to do it. Just tell them, hey, let me just do a rapid on both of these real quick so I can see what I'm working with.
Yeah, I say it's pretty unusual to have, something like that. And you really don't want to have a fight on the scene either.
And I'm 99% sure after talking to other said people that it was because, and I'm sorry, Andrew, I love to pick on you for this. Andrew looks like he's 12. So you know, they assumed that he was young and dumb and not capable of making really smart decisions. I'm sure they'd be thinking different if they ever had the need for him to treat them. So.
Yeah, if I could add, you know, not speaking specifically to that call, but you know, so that was kind of an anomaly. From in my experience, like most of the time, they don't want anything to do with backboarding or patient care or any of that. So, you know, oftentimes they're not even going to try to tell you what to do or get in your way. It's pretty rare that happens, and I think normally when they see EMS arrive, they are happy. You know, once the car cutting stuff is done, they're happy to transfer everything over to you and not get in your way.
And that's actually a good statement there, Andrew, because I know I had at times where I've been the only EMT on the scene, and as soon as we had the patient out of the car, I hadn't even finished strapping the patient. The fireman decided to take off. I'm like, wait a minute, get back over here. You're still helping with stabilization. Also, ironically, I was surprised I found out a couple of months ago that firefighters are not trained to lift patients, which I was really surprised.
No, firefighters are trained to take hoses and apply water to things that are hot.
Right. But always use your, you know, be polite, and you always use your support, because a lot of times moving a patient, you're going to find a lot of these patients are very heavy, very hard to move. As I said, you can use a stretcher to help you, you know, with it. But be polite. I mean, most of the firefighters I've ever dealt with on the street have been very cooperative, very helpful, friendly. But if you start a pissing contest on the street, it just gets worse. So don't start the pissing contest on the street unless
Yeah.
some of the patient's being endangered.
And if all else fails, you have your radio, call for a supervisor.
Right. Exactly. Right.
If things get too hairy, call me.
Right. So any other questions about backboarding collaring?
Barry, I found a very informational video about backboarding. It's like a minute long. Would you like to watch it?
Sure. Why don't you want to present it?
Sure.
Yeah. Why don't you want to present? Do I need to release the screen to you?
Oh, I already did it.
All right. Thank you.
I took over from you. So this is just a real quickie video on backboarding. It goes through it real quick. Sorry, it's 6 minutes. I lied.
Welcome to EMTprep.com. This is the spinal immobilization of a supine patient skill.
Welcome to the supine spinal immobilization.
Can you turn it up?
Here we will evaluate your ability to properly secure a patient to a long backboard. During the assessment, you will have an EMT assistant. Your patient's vitals are stable. To move the patient to the long backboard, I'd like to use both mine and the EMT assistant's phone. You are in charge of ensuring proper directions that are given to your partner. You may utilize any of the equipment shown before you, and I'd like you to review that now.
Ooh, look, tape.
CSI, my team safe. All right, so the first thing I'm going to do is I'm going to direct my partner to come in and place the head in an inline neutral position. And then I'm going to direct my partner to maintain spine stabilization. So once he's doing that, I'm going to check PMS and bilateral pulses. You check pieces. Can you tell me fingers on pulse? Okay. Now I'm going to move down to feet. Move off.
Jamie, can you stop for a second?
Yes.
Please make sure you check PMS before and after, and make sure you also state it in your narrative. You will get gigged on it big time if you do not state it.
Absolutely.
Barry, just for the new people, explain what PMS is.
I know.
Pulse motor sensory.
There you go.
Making sure they
Basically-
still have sensation and movement and pulses in their extremities after you've applied anything constricting.
Right. Thank you.
The only time you do not want to see that is after you've applied a tourniquet, because then they shouldn't have anything after the tourniquet.
Right. Thank you. Continue.
Pulses, sensation, and motor function are in all checked. All right. So the next thing we're going to do is we're going to put a seat collar on. So size my patient for the seat collar. Mark my seat collar, set it to the appropriate size. conform my color a little bit. Apply the seat collar. Ensuring that I'm not moving the neck around too much. Look at the mouth a little bit for me. Very good. All right. Now we have the seat collar on. The next thing we're going to do is we're going to lock roll the patient and place her on the board. So I'll have my other assistant come in and help me with that.
I don't know if you noticed that, but after he put it on, he asked if she could open her mouth a little bit. That's actually a pretty good thing to ask. One, it ensures that it's not too tight, and two, if you have to do anything with their airway, it ensures that you'll be able to actually do it.
So on the head count, we're going to roll the patient towards us, and then I will check her back, and then I will position the board, and then on the head count again. 1, 2, 3. Check the back really quickly, checking for any deformity. Position the board. All right. On the head count, 1, 2, 3. So now we're going to position her properly on the board. So we're going to move up and over 1 foot motion. All right. On head count, 1, 2, 3. Okay. Now we will secure the patient
Hey, Jan, can you stop for a second?
to the board.
Look at that guy. You notice how he lifted her and repositioned her? A good way to do this is around the, you notice how you went up higher on the hips? Use your belt loops and the pants are a great way to be able to grab a patient moving. Continue.
Using our strap.
Oh, he's using 9 foot. It's my
All
favorite.
right. Oh, those are 9 foots.
They're quick clips.
Right.
Yeah. They're almost like 9 foot. You're going to put them on the same way.
Keep your hands up for just a minute. Cross again.
Note he's securing the torso, not the arms.
Right.
One, so the torso secure. Again, I will check to make sure if I need to pad anywhere, don't need to pad anywhere. So next, I will secure the head.
He's using tape. Look at that.
Let's see that. Charles, you agree with me? Didn't we get our ass screened for using tape?
Yeah, we did. And then when I went through school, Jeff Williams actually, he tore into one of his paramedics that was doing it and was teaching us that. And as the senior instructor, they had a heated discussion.
Right. That's why we have the foam straps in the collar bag now.
And move down the body. All right, the patient secured to the board. Now I'll reassess CMAC. Okay, moving down to the seat. Can you tell me what you're doing? Okay, push down against my hand. All right, hold down. Okay.
Pulses, sensation, and motor function are present in all.
All right.
So you notice he checked PMS before and after to get a baseline and to make sure that he didn't tighten things down too tight at the end.
That's good. Thank you for sharing that video, Jamie.
No problem.
Any other questions? So it's a little short. So next week, Andrew, you're handling
Andrew's doing LVADs.
LVAS. Excellent. And then the week after that, I'll bring into the KED and the traction splints. And if I get a chance, we will also do a little short presentation on how to properly pack spider straps. And if I get very ambitious, I'll try to do a little quick presentation on the 9-foots. Once you learn a 9-foot, you'll never go back.
Oh my God, they're life. 9-foots are life.
And when you think of 9-foots, it's like lacing your shoes in a sense.
Yeah. I actually learned a really cool trick. I might have to come up here and help you for securing the feet even better. Once I get done with a 9-foot strap around the feet, you won't even be able to move it.
Really. Also, you notice in the video you watched, he did not secure the hands. But if you have patients, could be that you may have to. There's no reason why you can't take a cravat and secure the hands together so that as you're carrying that board, they're not dangling down and you're having the board hitting.
Cravats are the most underutilized tool you have in your arsenal.
Right. Okay. Any other questions? Anybody got any good stories before we close for tonight? No?
I got no stories.
Calls are dying.
No, I got no stories, but hey, for all the new personnel that are getting ready to either in the EMT school or get ready to get into it, those videos that Chief just showed, there's like 100 of those online. No exaggeration. I think I watched them every morning for 2 hours, maybe every morning where I was in the EMT school, and they helped greatly in the National Registry because the EMT class that you teach at MIFRE doesn't cover all the stuff that is covered in those videos. And a lot of the things that are in those videos actually are stated and discussed in the National Registry exam. So just food for thought. I'm not saying you have to study it or take quizzes on it, but seriously, when I was eating my breakfast and drinking coffee in the morning, I would absolutely watch and listen to those videos, and it helped me out a lot.
So I just put the link.
Point, Charles.
I just put the link to the one video I showed. They have a whole channel, so you can subscribe to that channel. It's in the chat.
Right.
If you're on
Right.
Zoom, you want to copy it.
That's very good. In fact, even for the older EMTs who think they know how to do it all the time, it's always good to go back and watch, because it's amazing how many in the last 2 years how many EMTs have not really had to backboard because we just don't backboard as much as we used to.
So I just had an ingenious idea.
Uh-oh.
Right. So once we are able to hold, meetings in person and do some fun things in person, I'd like to have Charles create a rodeo for a prize. We will call it the EMT Skill Rodeo. We will have backboarding stations, KED stations, and we'll do teams, and it'll be an event. So whoever can do it the right way in the quickest amount of time gets a prize. How do you guys think about that? You think that'd be fun?
Good idea. We need to include the stair chair on that also.
Oh yeah. Oh yeah. All sorts of things. I think it'll be fun running around
Yes,
trying to
okay.
backboard people as quickly as possible. Dave can be our first victim.
There you go. I like that even better. Yeah, the honorary person gets backboarded.
You'll have to stair chair him down from the upstairs and then backboard him.
Yes.
Can I
Can you
borrow
just-
one to bring home so I could do it to the kids here since I can't come up there?
It'll be a couple months from now. We'll
Yes.
do it once it's safe for everybody to hang out and have fun.
Okay.
And it's really important to practice these skills because you just tend to forget them. If you haven't done them, recently, you just don't remember. So that's an excellent idea. Sounds great. Okay, don't forget to put your hours into